Okay, party goers. For refresher 2016, the day we had to cancel, here is some pediatric resuscitation review for you. So let's get into this, and let's get into this thing from the top of everything we would normally do. So you approach these scenes. Everyone has their custom way to approach a patient assessment. But let's start from this, from a review standpoint, and let's just look at this from a across the room visual assessment that you guys do. Your appearance, or not your appearance, their breathing, and their circulation or their color. You see these things when you first arrive on scene, or at least at the patient's where they're at, not even not necessarily at their side yet. You're just looking at them. So we have a lot of decisions to make here. Are they sick or not? These, in this instance, we're talking about kids. Obviously, everyone likes to see a happy, smiley kid. I know, we like to hear happy crying babies too. That helps us some. We do not like to see the sick kids at all. So, start with our primary assessment. After that initial ABC assessment of appearance, their work of breathing, and their look or their color. So now we have ABCDE for airway, breathing, and circulation, disability, and exposure. First off is airway. Yes or no, they have an open patent airway. That obviously is an open patent airway. So, breathing. Yes or no. Quality, rate, retractions, sounds, like wheezing, or stridor, or even crackles. And a fairly easy thing to do in a very short amount of time is an SpO2. Circulation. Pulses. Central or peripheral pulses. Cap refill times. Very easy things to check, because getting blood pressures on kids isn't the easiest thing to do. If you're going to get blood pressures on kids, and as I mentioned and you all know, isn't the easiest thing to do. If you're checking a pressure on a newborn, and I don't know really why you would, but if you had a systolic blood pressure less than 60, that's a problem. Newborn should be 60 or better. That's, birth to 1 month. If we're talking about infants, we're talking the 1 month to the 1 year age group. They should be systolically blood pressure better than 70. The children, the age of 1 year to 10 years, we use this formula that we have here. Age times 2 plus 70. So let's keep it simple. A 5-year-old times 2 is 5 times 2 is 10 plus 70 is 80. So blood pressure for that age group should be at least 80, or they're considered, or better, I should say. If not at least 80, they're considered hypotensive. And everybody else over the age of 10 is at least systolic of 90. Disability, for all of our practical purposes, disability is your level of consciousness. But that depends on the child's age and where he is and should be developmentally. So, we have toddlers, we have infants that are brand new born, that are a month old. What should they be doing? Are they going to carry on a conversation? Of course not. But they hopefully make eye contact. Hopefully their eyes are open. And when you're close enough to them, they make eye contact with you. That's just the way it is. The 1 month old is going to be different than the 1 year old, and the 1 year old is going to be different than the 5 year old, and the 5 year old is going to be different than the 10, and so on. All of us have been there, so we know what they should be. Right? Make them naked, and I don't mean leave them that way, but we have to expose them long enough to look for rashes or weird marks that might tell us this is child abuse. Rashes are going to tell us a lot. Rashes are going to tell us that there's maybe a fever, and that rashes and fever is usually an infection. Secondary assessment. You've all seen this before. It's sample. SAMPLE. I'm not going to spend much more time on that. Scenario practice. Let's run through about 4 cases here. You and your partner arrive on scene, 8-month-old, trouble breathing. Ask yourself, what do you see? I know y'all do that. You're thinking to yourself, what do I see? Color, appearance, work of breathing. Your across the room survey. He's lethargic, increased effort to breathe, and pale. What are you going to do first? What's the fastest thing you're going to do for this kid? Probably some oxygen. How much? How fast? Probably originally putting him on some O's at 100% via mask is probably indicated here. What do you want to know about his ABCs? This is his airway, breathing, and circulation, and his disability and exposure. He's got some nasal secretions. So you're going to suction those, right? His breathing is interesting here. He's at a rate of 50. Nasal flaring. He's got some accessory muscle use, retractions, and an SpO2 of 90% with a stridorous respiratory sound. Let's go back a second here. Stridor. What does stridor usually tell you? Usually the stridor's noises heard on inhalation, and it's usually indicative of an upper airway issue. So, all right, moving on. Circulation, he's got a heart rate of 136. Normal peripheral pulses, normal cap refill. Good. That tells me that his pump is in good working order. This is probably respiratory. Sick or not? Yeah, probably. Not dying or anything. He's certainly in some distress, not failure. Our disability. This is he's lethargic, not interactive. What do you expect? What should an 8-month-old be doing? Probably making some eye contact, maybe even crawling around. If he's crawling around, maybe he found something on the floor that he's not supposed to have. Maybe you dropped something. Maybe you dropped a pill for when you were getting your own medicines out of the cabinet earlier. Did you even know you dropped it, or did you drop it and couldn't find it? Well, these little boogers will find it. So moving on here. Exposure, he's afebrile, no rashes, no marks. What's going on? I'm put on here probably an upper respiratory infection. If anybody disagrees, let me know, make some comments. Treatment for this. Start something fairly quickly so we can intervene with this distress and keep it from being failure. Suction we've done, keep an eye on that. It may have to resuction. Pulse oximetry, we get our baselines. They were 90%. That's not really great for this age. And our monitor shows a sinus tach of 136. He's got cough and respiratory distress, no allergies, no meds, no pertinent medical history. A couple hours ago, and he's been going on for 2 days. So at least it's 2 days. It's not an acute, sudden change. This is something that's been, I wouldn't say chronic for 2 days, but it's not an acute thing. So is this distress or failure? I'm going to go with distress. Probably upper respiratory infection. My treatments are going to be for sure oxygen monitor, maybe some albuterol. It's hard to say for sure what this is exactly going on, but I'm, maybe going to have albuterol ready. Probably not going to hurt too much to try and open up a little bit. Assisted ventilation, intubation. They're on the list here, but probably not. I got to be thinking about those things so that if he does get worse, I can intervene quickly and keep that failure state from coming on. Maybe thinking of intubation. So clearly, if I have to assist his ventilation, I have to consider intubation as the next step after that. So. Right, another scenario. This is a trauma call. We've got a 5-year-old hit by a car. The scene is safe. You're 10 minutes from a level 2 trauma center. You get on scene, you find an unresponsive 5-year-old breathing at 6 times per minute, and he appears to be pale. He's even got some peripheral cyanosis. So what are you going to do for him? What's the quickest, fastest treatment for this kid? Oxygen, IV, and monitor, probably a BVM, and thinking about intubation. Oxygen's going to go in pretty quickly, high flow, End-tidal CO2, yeah, I'm going to get to that here in a moment. Monitor showing a sinus tach. For ABCs, don't forget D's and E's. Airway is open with some basic maneuvers and an oral pharyngeal. Nasal cannula capnography is on, showing at 55. And because we have his airway opened with BLS and an OPA now, we're having to assist his ventilations with a BVM at the moment. So breathing, decide that to better secure his airway shortly here into this, we decide that endotracheal intubation is important. So tube is placed. We're still breathing in about 20 breaths per minute. We have decreased breath sounds on the right, and it's becoming more and more difficult to ventilate. And our SpO2s are only 70%. So circulation is 145. Cap refill is slow, 4 seconds. And 78 over 58. Remember, he's 5, so that should be 80 systolic. So it's already a little less than the minimum range for systolic pressure, and it says falling. So factor that in with that 4-second cap refill. It's a bit of an issue there. Disability is unresponsive. That hasn't changed any, and our assisted respiratory rates are still working at 20 with end-tidal CO2 now 46. Well, it's coming down. He's warm to touch. Obvious abrasions to arms and legs, chest, belly, head. Kind of a multi-system approach or a look to him. So you have that multi-system approach to his care. No significant blood loss, however, so that's good. But we have a pressure issue. So. Alright, treatment for him. The ET tube is in place and secured. Ventilation is still difficult. IV access is obtained. Monitor is on, still showing 145. Remember, we had right-sided breath sound problems. We have to consider the mnemonic known as DOPE for dislodgement, obstruction, pneumothorax, and equipment failure. So, obviously, we all know what's going on with him, probably. Let's run through this real fast. And I know you're going to do this really quick. And these slides going so slow with this animation is driving me insane, and I forgot to change this. So, he's unconscious, being assisted at 20, about an hour ago, and he was outside playing near the road. Okay. So, what's the problem? Distress or failure? Well, probably failure from trauma. Is he in shock? Yeah, but what kind? There's 4 kinds that we're going to talk about briefly. Hypovolemic, cardiogenic, obstructive, and distributive. Well, hypovolemic, probably. High suspicion because of the trauma. Cardiogenic, I don't have really reason to suspect that. His pump is probably ordinarily healthy. Obstructive, well, I have probably a pneumothorax going on here right now. So, yeah, I'm going to think hypovolemic, obstructive, distributive is, your sepsis, the infectious ones, the pump, or the pipe issues. So pump's okay. Probably got a hole maybe in the system, maybe some blood loss, and those lungs are probably pushing on that heart, causing that pump a little trouble to pump. Compensated, probably no longer at this point. I would say into the decompensated range that he's got some lung issues, no breath sounds, blood pressures are less than they should be. Treatment for him, first thing we're going to do is needle decompress. Where and how? Well, I'm going to do it pretty quickly. I'm going to do it either, second or third intercostal anteriorly, or I'm going to go third, fourth intercostal mid-axillary. You choose. Probably going to start some fluids at the same time. We shouldn't be on scene anymore at this point. We need to be transporting. At what rate? It's 20 mils per kilogram fluid bolus. So I'm just going to give him at least 1 to start with, and that may support him enough. If I fix that lung, it may all get better, but reassess, reassess, reassess. So what happened here? This unfortunate situation of this child being struck on the on his residential neighborhood street was, of course, not a good thing. You can certainly make those issues worse if you're not paying attention to your findings and being able to intervene quickly. So we did intervene with needle decompression. We have a large rush of air, and ventilations do get easier. We see an increase in end-tidal, or a decrease continuing in end-tidal CO2, and an increase in pulse oximetry. So we continue all of our BLS and ALS interventions and care until we arrive at the trauma center. Okay, another one here. You are dispatched to the scene of a 4-year-old that's unresponsive. Scene is safe. You're across the room, across the scene. Survey is unresponsive and limp. Breathing is none. Circulation is blue. So that's our across the room ABC: appearance, breathing, circulation. But these are things we're looking at, not, assessing. We're assessing this with our eyes, basically. Life-threatening call, yeah, probably this is not looking good at all. Chest compressions would probably start those right away. And you just have to decide how many people you have on scene. Are you doing this as a single rescue or a two rescuer approach? Under the age of, or at the age of 5 and younger, if their heart rates are less than 60, it's generally recommended to start compressions to support vital signs. His airway, our primary assessment, has no visible obstructions. His breathing is apneic. His circulation is without. His disability is unresponsive, and his exposure is unremarkable. Monitor shows a kind of an organized rhythm, but there's no pulse, and it looks like VFib to me. So pads and first initial dose of electricity, so we can defibrillate at 2 joules per kilogram. Then what? Well, of course, we need to start some high quality compressions and do CPR for at least 2 minutes. So while we're waiting for 2 minutes to pass, we got time to do a few things. We can get vascular access going. We can consider drugs like epinephrine, and there's our dose. 1 to 10,000 solution, and it's 1 or 0.01 milligram per kilogram, which is equal to 0.1 mil per milliliter per kilogram. We don't give it now. We wait a moment. We wait a couple of moments. We wait until that after that second shock to give the epinephrine. So Heart Association likes us to do it that way so that the heart is primed and ready for the drugs. And considering reversible causes is normally something we consider and we reserve for PEA. But this is a young person. This is VFib. I still want to consider maybe some causes I might be able to reverse, like hypoxia. I can take care of that. Hypothermia, I can fix that. Hypoglycemia, can fix that. Or hyperglycemia. Trauma, I don't have any reason to suspect trauma, but toxins, I need to consider that. I need to ask maybe a few more questions. Thrombus, probably not on my radar screen right now. Is it yours, though? Probably not. I'm guessing probably not. But these are called the H's and T's, of course. So which one of those are we going to treat? Certainly the ones we can identify and do anything about, like hypoxia, hypothermia, hypovolemia, hypoglycemia. How you're going to treat those is just whatever's appropriate for which one you think is most likely going on, and on scene or en route is what that wear is about. So that 2 minutes is gone. We do a rhythm check. It's the same. Electricity this time is going to be 4 joules per kilogram on the second dose around. Starting compressions and epinephrine is given now. So another 2 minutes goes by. We reassess. We have electricity. We have a rhythm of still VFib, no pulse. Electricity now is 4 joules per kilogram, and we consider amiodarone at 5 milligrams per kilogram. Summary of this case, to wrap this one up, it's you're going to continue everything you've already gotten started, transporting this kiddo, and reassess him on the way to the hospital, and hand him off to the ER staff. So, one more case. We have an 8-year-old child, difficulty breathing. The scene is at a campground, so we're outside. The appearance is awake and anxious. Breathing is increased. Circulation is normal. Here's this kiddo leaning against a tree. Does this look life-threatening? Yes or no? Well, probably not, but first intervention was going to be some oxygen and assess the patient's airway, breathing, circulation, disability, and so on. So we have some nasal secretions. We have Respirations at 50 with retractions, flaring, wheezes in 89%. Circulations at 170, cap refill less than 2, 95 over 55. Anxious exposure is warm to touch, 100.4 on your thermometer. So let's go with that for now. The wheezes and the temperature don't quite go hand in hand. So there's your monitor there, sinus tach. You've elected to put this child on capnography and a cannula, and your waveform starts to appear and it looks like this. So are they able to, yep, that shark fin look there to that waveform on your capnography is indicative of, an asthma or maybe a reactive airway issue. We'll start with some vascular access, IV, IO, drugs like albuterol and Atrovent, maybe even epinephrine can be considered. Sample history. One thing we gain out of here is that we've had cough for a little while now and wheezing for the last few hours with the cough starting. We treated this patient with the epinephrine, or not the epinephrine necessarily, although maybe albuterol and Atrovent to help relieve and open the airways. When the airways are opened and relaxed a little bit, we have now a less anxious, more alert child. Respirations are more within her normal limits at 30. Flaring is going away and retractions are gone. Capnography is no longer that shark fin look. It's more flat. We're seeing rates in the 30s and the high 30s probably at this point, so more within our normal range, because we want to see 35 to 40 if possible, and I'd say that's probably there. Some asthma mimics or sound-alikes, bronchiolitis, acid reflux. Yeah, you can have acid reflux in an 8-year-old, sure. Croup, yeah, possible. Upper airway, maybe. Obstructions. Do they still have their tonsils and adenoids? And do they a lot of us don't look in the mouth to see if we see anything in the oral pharynx, but if you do take a peek in there, do they look enlarged and white, and do they have the adenoids as well? If all your normal treatment actually works, traditional treatment for asthma is effective, it's probably asthma. I mean, it's not saying it's not like a diagnostic thing that says absolutely it's asthma, but traditional asthma treatments work. It's probably, walks like a duck is probably a duck. So in summary, we have our ABCs with the triangle assessment, triangle approach. And the ABCs of airway, breathing, circulation, disability, and exposure. Sample histories, treatment, transport. All right. Thank you.